All right, let's go through some EKGs. We're going to go through a systematic approach which includes rates, rhythm, and access, as well as intervals, morphology, and ischemia. Don't forget the 300 divided by box method, and review that your access, we usually use leads 1 in AVF. And when it comes to intervals, your P wave is going to be less than 200 milliseconds or 0.2 seconds. That's one big box. Your QRS is going to be less than 120 milliseconds or less than 3 small boxes. And QTC should definitely be less than 500 milliseconds in most scenarios. And know your ischemic patterns. So whether you have ST depression, T wave inversion, Q waves, you should be thinking about non-STEMI. And then, of course, if there's an ST elevation, you should be thinking about STEMI. Know your terminology. So unstable angina is chest pain usually at rest, and there is occlusion, but there is still blood flow going, and usually their troponin is not elevated. Non-STEMI is a severe occlusion, but there's still just enough blood flow. There is a troponin elevation in these patients. And then with STEMI, there's complete occlusion with transmural necrosis, and so that is the most concerning. Always, always, always review prior EKGs. All right, so we'll go through this one. Always take advantage of your vignette, 43-year-old male with chest pain. Let's start off with rate. So we try to find a QRS that's on the line. So 1, 2, 3, and about 3.5. So it's between 75 and 100, maybe in the 80s. So it's not that super specific. But you also have to follow the rule that if they have a regular rhythm, because if it's regularly regular, this rule doesn't work. So what I typically do is if you have a 10-second strip, like right here, this is 10 seconds, you can multiply the amount of blips that you have and multiply that by 6. So what does that give you? So that gives you 78 beats per minute, which is normal. I'll give you another trick. If you just memorize that 10 to 15 is your norm, you don't have to multiply by 6 anymore, because 10 is going to be the lower limit of normal, and then 15 will be the upper limit of normal. So rate is 78. What is rhythm? Rhythm requires multiple rules to follow. First and foremost, P waves should be positive in lead 2. If you notice here, your SA node to your AV node to the bundle of His Purkinje system is all going in this down and left position, which is going directly towards lead 2. And that's why P wave should always be positive in lead 2. Next, you should have a regular rhythm. That means that your R to R interval is spaced out regularly, and so you kind of guesstimate, but it looks pretty regular here. And there should always be a P before every QRS, which is here, and there should always be a QRS after every P. And that's just to rule out blocks. So the rhythm is normal sinus. Access, so 1 is predominantly positive, and AVF is predominantly positive when it comes to the QRS amplitude. We're specifically looking for an R wave. R waves should be positive. So the access is normal. The PR interval has to be less than 200 milliseconds or one big box. So if you look between one P wave and the beginning of the QRS, this is all within one big box, so there's normal PR interval. The QRSs are less than 3 small boxes, and the QT is less than 2.5 big boxes. And 2.5 big boxes is 500 milliseconds. So intervals are within normal limits. Morphology means that the P wave in lead 2 is normal, your QRSs don't have any bundle branch blocks or widened QRSs, and then there's no T wave hyperacuity, there's no flattening, there's no inversion, so morphology is normal. And there's no significant ST elevation in contiguous leads or ST depression suggestive of an ischemia. So overall, this is a normal sinus rhythm EKG. And if you notice, it takes a lot of work just to read one EKG, even if it's normal. So this is a normal sinus. All right, take a second, pause the video, review this EKG to the best of your abilities, and come up with your conclusion. And then I'll give you the answer. So for rate, there are 12 blips across this 10-second EKG strip. So that's normal. Remember, 10 is multiplied by 6 is 60, so this is normal. If you can tell, the rhythm is a little bit abnormal, so you can see that these QRS, or the R to R intervals, are spaced out regularly, and then there's this huge gap, and then spaced out, and then a huge gap, spaced out, huge gap. So it's a regular rhythm already. The P wave is positive in lead 2, and this is where my stepwise approach doesn't always happen linearly. So I'm not looking at intervals at step 4. Right here I can tell that the P wave is coming before the QRS, then there's a T, and then the PR is starting to get longer. So I am looking at intervals when I'm also assessing for rhythm. And then you see the PR interval is getting longer, and then there's a P wave without any QRS, P wave, QRST, P wave, QRST, P wave, and then there's no, so this is a lone P wave without a QRS that comes after it. So when you have a prolonging PR interval with dropped QRSs, you should be thinking about second degree, because either secondary type 1 or type 2 can cause dropped QRSs. So the one where PR gets longer, 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 think about second degree type 1. Access is normal. And I'm going to skip a couple of steps so that we can get more and more information quicker. But the ST elevation is present in 2, 3, and AVF, with ST depressions in 1 and AVL. So those are reciprocal changes to an inferior wall STEMI. And always connect the dots with your vignettes. This guy's coming in with chest pain, with hypotension, and an inferior wall STEMI, which includes the RCA as its distribution. RCA infarcts are preload dependent. They can also cause bradycardia because it usually supplies blood to the SA node. And the right ventricle is preload dependent, so typically what do you do for these patients? How do you manage them? So all in all, we have our inferior wall STEMI, we have our second degree type 1 AV block. So what is the treatment? Pause the video and think about it. Number 1 should always be aspirin if you're worried about a STEMI, so that should always be number 1. You want to avoid beta blockers and nitros in inferior wall STEMIs. And then initial best step for these patients, you want to give fluid. So IV fluid would be a great option for inferior wall STEMIs or RC occlusion. And if fluids don't work or they start looking like worse and worse heart failure, then you may want to start giving them dobutamine, dopamine. Levophed is always a good first option for pressors in general. So again, always look at your answer choices and see if what is the question asking. Is it asking best initial step? If aspirin's there, then number 1, but if aspirin's not there or aspirin was already given, then IV fluids should be right there next. And if it asks what medications to avoid, you don't want to give beta blockers like metoprolol, you don't want to give nitroglycerin in these patients. Alright, so we have a 23-year-old female with anxiety who drinks a lot of coffee. Go ahead and review this EKG, pause the video, and then come back to me for the answer. So there are 12 blips on this 10-second lead, so that is normal. We can't do access, so we're going to focus on rhythm. This is a lead 2, which is great, so we should see a P wave that's positive in lead 2. And here the PR interval looks to be sort of pretty normal. QRS, T, P wave, QRS, T, P wave, QRS, T. And if you notice the R to R, it looks spaced out regularly up until this point. So what happens? So start looking at the P waves. This P wave looks the same as this one, as this one, as this one, and then there's some notch that forms that doesn't look normal in morphology as your other previous P waves. And then it comes back to normal again, normal again, normal again, normal again, and then you see this new notch. Okay. So if you notice right here, this QRS and this QRS, this comes a little bit earlier with an abnormal P wave that precedes it. So that is called a PAC, a premature atrial contraction, which is a misnomer because we're looking at electricity, we're not measuring contraction, but this is a premature beat that forms due to some sort of irritation in the atria that are generating this beat that's outside of the sinus node. That's why you don't get a positive P wave or a normal looking P wave. So this is just PAC. And these can be generally benign, but if you start getting more and more of these, then you can get other types of arrhythmias if it's very persistent. Alright, you know what to do. Pause the video. This patient is a 36-year-old female with asthma exacerbation. Go ahead and review it. So there are 13 blips, so that makes it normal. The R to R is pretty regular. There's a P wave before every QRS, but there's not a positive P wave in lead 2. So this is what's called an ectopic atrial rhythm. That means that it's not coming from the sinus node. Remember, lead 2 sees depolarization coming towards it as positive. So if depolarization is going away from it, it's going to be upside down or inverted P wave. And there's no way for the SA node to go backwards and still generate a response. So that means that this beat may be coming from somewhere else. So it could come from any part of the left atria, the right atria. So just to give you an idea, if it's lead 2 that we're looking at, there may be some irritation here that's propagating this way and generating an inverted P wave, and one of those ripples generates down the AV node in the His-Purkinje system. And one other thing that you notice, you see here there's a P wave that's inverted, QRS, T, but then there's this extra hump that comes right after the T wave, and that's not a P wave because that's the P wave right there. So if you see an extra bump between the T wave and the P wave of the next cycle, where the TP segment is supposed to be flat, that's called a U wave, and connect the dot. If you have a 36-year-old female who's coming with asthma exacerbation, think about like what medication could have caused a U wave. And this is usually a sign of hypokalemia if you see a U wave. You can see T wave flattening as well, but not always. And you should be thinking about too much beta agonist like albuterol that's been given, because that causes hypokalemia by bringing all that potassium, serum potassium, intracellularly. And the other thing, if you notice here, is 1 is positive, but AVF is predominantly negative. So this is left axis deviation. So all in all, you have ectopic atrial rhythm, you have these prominent U waves that suggest of hypokalemia, probably from albuterol, if that's what the question is asking. Say, like, what's the cause of the U waves? What's the cause of the abnormal EKG? And they give you all these different medications. Look for a beta agonist like albuterol. All right, review this one, pause your video, and then come back for the answer. 86-year-old female who presents with UTI sepsis. So already we can tell that based off of how many blips there are within a 10-second EKG, it looks tachycardic, but it looks regular. So tachycardic, that's regular. You should be going down your differential of different types of tachycardia. If you have regular tachycardia and it's narrow complex, remember we talked about morphology. It doesn't always have to look linear. You don't have to like wait to do morphology at step 4. So if you see, these are narrow complex QRSs. So if you have a narrow complex tachycardia, that means it's probably coming supraventricularly. It's coming from the atria. That doesn't necessarily mean it's an SVT. SVT is an umbrella term, which basically describes many different types of tachycardia. But SVT is just, when we imply that, we're implying special types of tachycardias. So this is a tachycardia, a supraventricular type of tachycardia, like versus a ventricular tachycardia. So if you had wide complex, then your QRSs would be wide. So instead of them looking like this, they look like kind of this sluggish shaped appearance. So far we have a regular narrow complex tachycardia. We have P waves at least before every QRS, and the P waves in lead 2 are positive. So far my differential is sinus tachycardia. You get lead 1 is positive, and AVF is kind of like a little bit negative more than positive, so there may be some left axis deviation potentially. You also see these QRSs that are encroaching the next lead space. So you see this one, they're all like kind of getting crowded because these QRSs are becoming so huge. This is usually a sign of left ventricular hypertrophy. And left ventricular hypertrophy is a sign that somebody probably has underlying hypertension. That's probably the most easy way to prove to someone that they have hypertension. If they say that, oh, my blood pressures are normal at home. So all in all, you have an 86-year-old female with UTI sepsis. This is sinus tachycardia. This is a very common response to see with sepsis and any type of general infection. You might expect to see sinus tachycardia. Sinus tachycardia can happen for a multitude of things. If you're having anxiety, if you just ran a marathon, if you're having a PE, there's a lot of different things. If you're having pain, that too. All right, 36-year-old female with palpitations. Again, you can tell that this is already tachycardic. It looks pretty regular. It's narrow complex. And you also see here that there are these inverted P waves. So just like how we saw with a regular rate before, we called it ectopic atrial rhythm. Now this is just called atrial tachycardia. And atrial tachycardia can be caused by a multitude of things, like we were talking about caffeine. With somebody who's drinking too much coffee, you can get PACs. You can get tachycardia from that. You can get tachycardia from catecholamines, from drugs like meth and cocaine. So lots of different things. So overall, it's non-specific. All right, so you have a 69-year-old male with COPD who presents with shortness of breath. Go ahead and do this question. Pause your video. So this has at least 18 blips that I see on a 10-second strip, so they're tachycardic. You can tell that the R to R is not spaced out regularly, so it's irregular, and you may even be tempted to say irregularly irregular, which you're not wrong when you say that. If you think irregularly irregular, automatically number one should be AFib on your list, but here you can see in leads 2, you have a P wave. You have 3 different types of P waves, so this is not AFib. AFib is not the only arrhythmia that can cause irregular rhythm, but if you see 3 different P waves with a tachycardic rhythm, that's called multifocal atrial tachycardia. So how that happens is maybe the SA node generates one of those action potentials, then you get one that's coming from here, then you get one that's coming from here. So it's all over the place, but it's still supraventricular rhythm. It's not coming from the ventricles, but it's irritation all throughout the atria, and this is usually a sign of that comes from pulmonary disease like COPD. And this patient's coming in with COPD and shortness of breath. So again, pulmonary disease, think about multifocal atrial tachycardia. All right, go ahead and pause your video for this one. You have a 45-year-old male, presents with palpitations. So this is a tachycardic rhythm. There are irregular spaced out R, so R to R interval is not consistent. And there's no discernible P wave. Maybe you think that that's one, but again, you should be a consistent P wave. So no discernible P wave across leads 2 especially is the best one to look for. So regularly irregular rhythm, it's tachycardic with no discernible P waves. Automatically you should be thinking about AFib. And specifically this is AFib with RVR or rapid ventricular rate. So AFib by itself, if the rate is 70, 80, doesn't always cause symptoms, but when it gets that's why we get worried of some, because with atrial fibrillation, you get fibrillation of the left atria, and it's shooting all these action potentials so they can generate a tachycardic response. So typically that's why we care about treating it. That's one of the reasons. So ask yourself, what is the treatment for atrial fibrillation? Think about it before moving on. You always want to assess for anticoagulation in these patients because the left atria, left atrial appendage specifically, can form clots because that blood that's fibrillating is not going anywhere. And it stagnates. When blood stagnates, it causes clots. And so those clots can shoot out, cause strokes, cause mesenteric ischemia, it can cause ischemic foot, because that clot is an embolus, it can go anywhere. You want to consider giving them either a beta blocker like metoprolol or a 9-dihydropyridine calcium channel blocker like diltiazem. Amiodarone is a good second option. Digoxin we usually reserve as a third line. Flecainide is a really good one when it comes to antiarrhythmic approach. So typically we try to at least rate reduce in the early stages if we can, because we need to get those heart rates slowed down, because if they're tachycardic for too long, they can actually get tachycardic induced cardiomyopathy, so they can go into heart failure. So at least get the rate down. Then you probably want to put them on amiodarone if they're elderly, like 70, 80 years old, but if they are younger, don't forget this causes a lot of different problems. So it can cause thyroid disease, you can get hypothyroidism, so TFTs. It can cause pulmonary fibrosis, so you want to get PFTs, and then it can cause liver disease, so you get LFTs. And if they're unstable, you want to synchronize cardiovert them. So that means if they're hypotensive, giving a beta blocker in somebody who's hypotensive is not a good thing. So you're limited with your options, and so you want to synchronize cardiovert, meaning don't direct cardiovert them, because you can put them into a ventricular arrhythmia. Synchronize is a setting when you shock them that tries to avoid the T wave, and especially the first half of the T wave, which is the highest risk for generating a ventricular arrhythmia if you shock them during that part of the phase. All right, so you have a 65-year-old male who presents with a pre-op visit, so they're asymptomatic. And this is the reason why we get EKGs when somebody's coming for a pre-op visit. You want to exclude any type of arrhythmia that needs to be treated, or any type of ischemic findings like Q waves or something like that. So go ahead and review this one, and then I'll give you the answer. So the rate is normal. It's not tachycardic, but you do see, and you see QRSs that are spaced out regularly, so the R-to-R interval is normal. So this is a regular rhythm, but you see sawtooth wave patterns. So you see these P waves that are being generated, and they're formed also, you can't see it, but there is a P wave probably generated here as well. So this is like 3-to-1 conduction or 4-to-1 conduction. So that means like for every 1, 2, 3, 4 P waves, there is 1 QRS. And so if you see sawtooth wave pattern, you should be thinking about atrial flutter. And atrial flutter can present as regular rhythm or an irregular rhythm. So we've just described 3 different diseases that can cause irregular rhythm. And those 3 rhythms are AFib, aflutter, and multifocal atrial tachycardia. So this is atrial flutter with 4-to-1 conduction. All right, go ahead and review this one. 23-year-old male with palpitations, dizziness. You can tell that this is already very tachycardic. It appears regular. The R-to-R looks spaced out pretty regularly. And you may think this is a P wave. It's not. This is actually a T wave. So you don't see an actual discernible P wave in this. So if you see a regular tachycardia and a very fast tachycardia, we're saying like 160, 180, you should be thinking about supraventricular tachycardia. When you see regular narrow complex tachycardia without discernible P waves, actually the P waves are this little notch that you see right there. So you see a notch there, a notch there, a notch there, and I'll explain why. And this is what I mean when I say be careful about calling it SVT, because technically that's an umbrella term, but when we say SVT out in the field, we're trying to imply this particular one. So if you have AV nodal reentry tachycardia, where there's this constant loop of depolarization that's happening within the AV node, and some of it gets depolarized and causes these QRS amplitude signals. Some of them also go backwards into the atria, and that's why you see a P wave after a QRS. So remember that rule we were talking about, P waves before QRSs. We don't want to see P waves after a QRS. And so this is one of those rules you want to follow, is that if you see a P wave that's generating, so there's an axis potential that goes downward, and then also after that QRS is formed, then there's an action potential that forms away from the bundle of His, and that's why you see a P wave after the QRS. So this is supraventricular tachycardia, but more likely AVNRT, if they give you an option, like which of the following is most likely. About 20%, 25% of the time you see SVT is usually AVNRT. But then you can have AVRT, which WPW is an example of AVRT. AFib can cause very fast heart rates. Aflutter can also cause very fast heart rates. All right, so you have a 70-year-old female with right-sided CHF, pulmonary hypertension, tricuspid disease. So all of these are causing right-sided disease, right-sided heart failure, obstructive. When we say obstructive shock, if they were hypotensive, that's usually right-sided heart disease. And so look at lead 2, and we're going to talk about morphology. So look how different this P wave looks than the other P waves that we've seen in previous EKGs. This P wave is almost the same size as the next QRS over. And so if you see these huge P waves, you should be thinking about right atrial enlargement, and that's what I wanted to show you here. So if you see right atrial enlargement, that means that that P wave is greater than 2 millimeters usually, which is 2 small boxes upward in the inferior leads. So you're at least, especially when we're looking at lead 2, we've been looking at lead 2 a lot for P wave. And so P waves should have this nice hump to it. Right atrial enlargements are usually bigger, and then left atrial enlargement has this bimodal form to it. So think about it like that depolarization starts at the right atria and then has to depolarize to the left atria. And so if the left atrium gets bigger for whatever reason, like mitral stenosis, that left atria has gotten bigger and it takes more time to depolarize it. So that's why it's starting to spread out. So I typically think about the P wave as one side being the right side, the earlier side, and the later side being the left side, because it's depolarizing both and just forming one mound. And to me, that's how it makes sense when you start to see the left atrial enlargement. You start to see that mound separating from the initial one. So that's how it would look like. Right atria is depolarizing first, left atria is taking a lot longer to depolarize. Go ahead and review this one. This is a 66-year-old male, smoker, has a history of coronary artery disease, was coming in with chest pain. So this has 10 blips across it, so it's on the lower limit of normal, so like 60 beats per minute. It's a pretty regular rhythm, so R to R is spaced out regularly. There are P waves before every QRS. And then you, of course, you're starting to see some abnormalities as you pick up this. You know, like remember I said it's not linear, how you approach EKG systematically. And look at lead 2. So this is what I was talking about. You get that bimodal kind of Mickey Mouse type of sign, not Mickey Mouse, but 2 mounds across it. So that's left atrial enlargement more likely. And you also see these huge QRSs. So you can see like they're starting to encroach each other's space. So they probably have left ventricular hypertrophy. And certainly last but not least, we're looking at seeing ST depression with T wave inversions in your lateral leads in V4 through V6, as well as ST depressions in 1 in AVL. So if I check the troponin on this patient and it was elevated, this patient's having a non-STEMI. And you do see these Q waves, these deep Q waves. That could be a sign of an old MI. This patient had a stent. Who knows where the stent is, but maybe the stent was in the right coronary causing these Q waves. So again, overall, this patient has left atrial enlargement, but the biggest hallmark finding is ST depressions and T wave inversions in the lateral leads. So I would be thinking about left circumflex disease in that patient. And the treatment is very similar to STEMI. You just have a little bit more time to, it's not emergent to do a cath on these patients, but you still need to get a cath done within 24 hours versus 90 minutes for STEMIs. And so you still give them aspirin, you still give them nitromorphine, all that stuff. I say monobaps, so beta blocker, statin, Plavix, all those different medications. You don't want to stress these patients, especially if their troponin is elevated and they already have these ischemic findings on EKG. They're basically, think about it like their heart's already stressed. So what is a stress test going to do? All right, before we do our next one, I want you to keep in mind how normally AVR looks and V1 looks. You usually have predominantly downward deflecting in AVR and V1. Everything usually is upside down. I don't like to use the term inverted because inverted means that it's upside down or flipped from its normal state. So this is just normal for V1 and AVR to look like that. And if you think about it, lead 2, everything is upward, and what we are kind of used to seeing with our eyes with lead 2, and AVR is in the opposite direction, so it makes sense for everything to look upside down. And V1, if you add that 3-dimensional approach to it, everything is going kind of away from V1 as far as the depolarization goes, so V1 sees everything as upside down as well. So use that information as we do this next EKG, so go ahead and pause your video for a 67-year-old male with COPD, CHF, who presents with syncope and shortness of breath. So they're a little bit on the upper limit of normal for rate, so it's slightly tachycardic. The R to R interval looks spaced out regularly. There are P waves before every QRS. And when it comes to access, so you have more downward deflecting in lead 1 and more upward in AVF, so that's more right axis deviation. But look what I was just teaching you with AVR and V1. You have upward deflecting, so you have a pretty significant R in AVR and V1, which is not normal. You also have this ischemic pattern. You have ST depression. And again, this T wave should be naturally upside down, but you have ST depression in lead 1, and you also have ST depression in V2 and V3. And we haven't talked about R wave progression, but usually V1, V2, and V3, they're all downward deflecting when it comes to the QRS. By the time it gets to V3, V4, V5, then you start to see the QRS is becoming upward deflecting, and that's the direction that depolarization is going when you add that 3-dimension to it. So this patient has early R wave progressions already forming at V1, and in combination with these ischemic patterns with a patient with COPD and heart failure, you start thinking about cor pulmonale and different types of right ventricular strain. So with the right axis deviation, the right ventricular hypertrophy with strain, this can be caused by a multitude of different diseases that cause right heart disease. So if somebody has a history of right-sided MI, PE can do it, that causes pulmonary hypertension. Anything that causes pulmonary hypertension, COPD causes cor pulmonale, so all of those things can cause this type of pattern. All right, this is an interesting one. You got a 29-year-old male with nosebleeds, elevated blood pressures, but no chest pain or shortness of breath. So think about your differential before you even look at this EKG. Then review this EKG, pause your video, and then come back to me. So the heart rate's on the lower limit of normal, so it's about 60. The rhythm is pretty regular, so R to R is spaced out evenly. And there's a P wave before every QRS and positive P wave in lead 2. There is left axis deviation with positive in lead 1 and negative in lead F, AVF. The QRSs are slightly widened as what we don't normally see it like this. You also see that encroachment again, which we were talking about earlier, which is a sign of left ventricular hypertrophy. And then you see like this ischemic pattern. So if you look at V6, you see a ST depression. V5, you see an ST depression. I just want to clear that out. So yeah, V6, V5, and even a little bit of abnormality in AVL and 1. So if you're thinking about cocaine because it's a young guy with nosebleed who's hypertensive, has ischemic patterns, you're thinking coronary vasospasm, you're actually wrong. That's not the case. What's going on for this patient? Again, this patient doesn't have chest pain or shortness of breath. That should be on your differential, but for that, for the sake of this EKG, that's not the right answer. So this patient doesn't actually have ischemia like in a non-STEMI. This is called delayed repolarization, and that could be a sign from left ventricular hypertrophy. And so if somebody who's young, who you wouldn't expect hypertension, who has signs of hypertension, that's called secondary hypertension. If you have a 50, 60-year-old patient who's obese and who has diabetes, kind of expected to see hypertension in those patients, and that's called primary hypertension. And but even in those patients, if they have resistant hypertension, meaning you're giving them 2, 3 different medications and it's still hypertensive, then you have to be looking for secondary causes. So this patient specifically has secondary hypertension. And so we think about renal artery stenosis, hypercortisolemia, hyperaldo, thyroid disease. But this patient actually has coarctation of the aorta. You could get, chronic cocaine use, you can get this type of presentation. But usually these patients, if they have ischemia, it's causing chest pain, so that's less likely. And then don't forget pheochromocytoma. If you have a young person who's coming in with headache, who's coming in with palpitations and sweats, you should be thinking about pheochromocytoma, especially if they're having hypertension and tachycardia, a young person who kind of looks like they're having an anxiety attack, but they're not actually having an anxiety attack. So this patient has coarctation of the aorta, which can be congenital, and it doesn't necessarily always have to be found early in life. So if they have a pretty significant coarctation as a kid, once the PDA starts closing, then they'll start showing signs of cyanosis. And so you can give them prostaglandin, a medication to try to keep that PDA open. But sometimes these patients go to their second, third decade of life before it's being found. And this is a X-ray or an aortogram that shows that kink in the aorta. And that kink in the aorta can be anywhere, but usually kind of like in the descending part of the arch or what have you. And so if they ask you what's the next best step in testing, you want to get blood pressures on these patients. If you get blood pressure on the right arm and the left arm, and there's a difference of 20 beats per minute in the systolic pressure, then that might be a sign of coarctation. Or if you see rib notching, so you see this like degradation of the rib, and that's because the blood flow that is supposed to be going into the aorta now starts to go elsewhere. So if it's going into your internal thoracic arteries that feed the ribs, and these ribs, blood vessels, the arteries start to get bigger to compensate to try to bypass this coarctation and then still get blood down to the descending aorta and to your legs. And definitively, these patients need surgery. So yeah. Okay, you know what to do. 65-year-old female, recent MI. Go ahead and pause your video, review this one. So you already can tell that it's abnormal just because of these abnormal rhythm beats that are forming. But if you count all of these, it's supposed to be 14, so that's normal, at least for the rate. The rhythm, if you see there's this abnormal QRS that's being generated every other beat. And if you look here, you have a normal QRS, and then you have a widened QRS. So it is apparently normal, but then every other second beat, you have this abnormal rhythm that's interjecting itself. So if you have every second beat, think about the term bigeminy. So if you see a PVC, which this is a PVC, if you see one PVC, which you've probably seen in a previous EKG, you see one PVC, that's just called a PVC. But if you see it every other beat, think about calling it ventricular bigeminy. So what do you do for bigeminy treatment? It definitely depends. If they're sick and they have an acute illness, it's probably nothing to do. So I just monitor. But if they've had a history of MI, and especially recent MI, one of the risk factors for post-MI complications is ventricular arrhythmias like VTAC, VFib. So you may want to treat them sooner rather than later, or just keep an eye on them. Sometimes getting their electrolytes fixed can help do the trick as well. So you certainly don't want to stimulate them. Any stress, caffeine, anxiety, sympathomimetics, alcohol, all these things can cause worsening of this arrhythmia. And maybe you want to do a Holter monitor for them when they discharge, or if they haven't been admitted yet, maybe 23-hour observation. Do another ischemic eval, such as an angiogram or echocardiogram, to see if they have any heart failure. And if they certainly have heart failure with an EF of less than 30% or 35%, especially, you should be thinking about AICD in these patients. And amiodarone is a helpful medication when it comes to ventricular arrhythmias, as well as AFib, which we talked about earlier. And if we see a PVC every second beat, it's called bigeminy. If we see it every third beat, which is less frequent, trigeminy or quadrigeminy. If you see PVCs 2 in a row, call them couplets. If it's 3 in a row, call them triplets. If it's more than 3 and it stops within seconds or a few minutes, that's called non-sustained VTAC. And if it's not going away at all, these patients are usually either symptomatic severely or they're dead. That's called sustained VTAC. All right, now we see this funky rhythm, 88-year-old female with sepsis, but she's got a relatively normal blood pressure. So go ahead and review this one and pause the video. There's not much else to say other than it's an irregular rhythm, and you see this wide complex QRS. So if you see wide complex QRS is really tachycardic rhythm. This is VTAC, until proven otherwise. You see monomorph, so the form of each of these is the same. So one form, monomorph, called monomorphic VTAC. And since this patient has a normal blood pressure, they're awake, they're alert, we call it stable, even though it's really, really bad. I mean, it is bad, but versus unstable, they're hypotensive, or they're dead, and you might be coding them. So this is a sense of urgency. You got to treat these patients immediately. If I'm in the middle of the night working in the hospital, amiodarone drip or giving amiodarone push can be helpful. I'm getting cards on the phone and thinking about pushing lidocaine or procainamide. I'm getting a BMP and looking at electrolytes and correcting them if they're abnormal. And certainly, if you don't have any time, let's say they become hypotensive or they pass out and they're presumed dead now, and you have to go through the ACLS protocol, and you can DC cardiovert these patients. Sometimes there's an argument to DC cardiovert them right away, but if their blood pressures are great and they're asymptomatic, sometimes we try these other medications and stuff before we DC cardiovert, but we keep the crash cart right next to them. And if this keeps happening for whatever reason, then you need to get an AICD for definitive long-term management in these patients. All right, so we have a 76-year-old female who comes in with pre-syncope, typically has like a normal looking rhythm, and then until it doesn't, and you see that this looks kind of like VTAC as before, but some of these forms are bigger, and then some of these forms are smaller. So it's bigger, smaller, bigger, smaller. Usually we don't capture it like this on an EKG, we capture it on telemetry, and it's called the twisting of points or torsade de points, and the best initial treatment for these patients is going to be magnesium. So again, torsade de points, you want to give IV magnesium, and you just give both loads of it. And especially if somebody comes in with QT prolongation, remember we said if it's greater than 500 or if it's even like 480, the board's questions will be somewhere around this range. You should be discontinuing medications that can prolong it. So a lot of antipsychotics, antidepressants, hydroxychloroquine can do it, azithromycin can do it, so a lot of different medications can do it. So you just want to discontinue that because that's an easy first step if that's an option to discontinue medication. But first and foremost, if you see torsades, give them IV magnesium. If they're on different medications like the ones I just mentioned, you want to discontinue them. You do want to correct potassium and calcium because those can cause QT prolongation, or especially calcium can do it. And sometimes pacing, if you keep them in a tachycardic state, that typically shortens the QT, and if it's, if they're in the bradycardic state, that may generate this torsades, in a bradycardia versus a tachycardia, which would be more protective. All right, let's do this one. 65-year-old male who comes in with chest pain. Go ahead and pause your video. You have a fairly regular narrow complex rhythm that's being formed. You have a P wave before every QRS, P wave QRS. The biggest hallmark finding that you see here is you see these huge T waves, or you can even argue that there are ST elevations in V2, 3, 4, maybe even a little bit in 5, as well as AVL. There's definitely ST elevation and 1. And then you see these reciprocal changes with ST depression in the inferior leads. So it's definitely an anterior wall STEMI. You can even argue because of 1 in AVL that it might be an anterior lateral wall STEMI. I don't see V5 and V6 included, so hesitant to say that, but it can also be that as well. And just like any other STEMI treatment, it remains the same: aspirin first. Nitros, beta blockers are fine in anterior wall STEMI, especially just keep an eye on the blood pressure. If the blood pressures are low, you want to avoid those. All right, 44-year-old female who presents with epigastric abdominal pain, and this is a very common occurrence. People who complain of abdominal pain, we start focusing too much on abdominal differentials, but we should always have MI or any type of heart insult included with somebody who's coming out with epigastric pain because it's a neighboring organ. Go ahead and pause this video, review, and come back to me. So the main hallmark finding for this one is that you see ST elevation in 1, AVL. You see these, especially these large T waves kind of being formed here. And so this is a lateral STEMI. And then also always look for those reciprocal changes. So you see ST depressions in 3 and AVF. You can even argue a little bit in 1 and maybe even V2. So this is a lateral STEMI. So you have a 49-year-old male who's coming in with chest pain. And if you go through your systematic approach, it's a pretty normal rhythm, and there's 14 blips, so it's a normal rate. Access, you have positive in 1, and a little bit of positive in AVL, so I'll call that normal access for now. And this one's really easy to miss. Remember we talked about V1 has to be, usually everything is facing upside down. We have a pretty large R in V1 with this ST depression in V1 and V2. And so this can be a subtle finding of what I'm about to explain. You always want to have a low index suspicion of posterior wall MIs in these patients, and this is how subtle it can be. You can just see it in V1 and V2, and that's it. Usually you want to get EKG leads on their back. If you can get 3 extra leads on their back, and you may see an STEMI forming from behind. All right, 55-year-old male who comes in with chest pain. Go ahead and review this one. So again, normal neural complex, regular rhythm. 1 is positive, AVF is negative. So that would make that left axis deviation. And then this one, you see these hyperacute T waves, which could happen in the early minutes of a forming STEMI. So you may not see a ST elevation all the way through, but you do see this either J point elevation, which is the end of the S wave, and you see the ST is slightly elevated in V2, V3, even V1, which would make me worried about a STEMI. So overall, this might be an early anterior MI for this patient. So talking about morphology, we alluded on T waves a little bit earlier, but you can get ST depressions, either symmetric or asymmetric, meaning one area is a little bit deeper than the other. You can get biphasic T waves, you can get peaked T waves and hyperacute T waves. And when you see these two, you should be thinking about either hyperkalemia or, again, we just mentioned about early STEMIs. So we have a 47-year-old male, diabetic ESRD on dialysis who missed 3 sessions of dialysis. So that's a week's worth. And so if somebody comes in with dialysis that's been missed, you should be looking for complications of that. So reviewing this EKG, you see that they're probably tachycardic. It is a regular R to R interval, and you may be thinking that these are Rs, but they're not. So if you look at other leads vertically, you can tell the difference. So these are all T waves, and the QRSs are smaller than the T waves, which is interesting. Another way to prove what's a QRS and what's not, if you see in the anterior leads, you can see clearly this is a QRS, so right below it should be a QRS, and you see the T wave is bigger than the QRS in the limb leads, such as lead 2. If you see in the limb leads, so that's all 1, 2, 3, AVR, AVL, AVF, if you see T waves that are greater than one big box, those are enlarged T waves or peak T waves. And you can see here with the anterior leads, the precordial leads, the T waves are much bigger than what we're used to seeing. Look at V4, it's almost spanning 2.5 big boxes. So sinus tachycardia, and when you see peak T waves, they're going to ask you what's the best initial treatment for this patient. So think about that. Somebody who misses dialysis, you have to think about hyperkalemia. And so the first initial treatment that's best for these patients is always going to be calcium gluconate or some form of calcium. Albuterol nebs and insulin both are temporizing measures, meaning that they help in the short term, but if you don't actually remove that extra potassium that's been brewing in their system, it'll all just come back, because both albuterol and insulin cause potassium from the serum to go intracellularly. You can also do bicarb drip. Fluids can help sometimes dilute that potassium. And then more permanent measures are going to be loop diuretics if they produce urine. Imagine this patient is an ESRD patient. We don't know if he makes urine or not, and then emergent dialysis is going to be a good definitive option. If left untreated, you start to see these T waves are getting way, way bigger, and you start to see this irregular arrhythmia forming. So the QRSs are starting to get widened, and the T waves are starting to get widened, and we're starting to lose even the P wave. It's being difficult to see what's the P wave and what's the QRS. And if you start seeing this is considered a sine wave, which kind of looks like an S. And it's just getting even worse here. And these patients are going to code if they haven't already done so. All right, take your time with this one. You have an 84-year-old female who's coming in with syncope. So think about your differential for syncope, review this one, and get back to me. So you have a very significant bradycardia, as noted on here. And so when you think of bradycardia as your differential should be blocks. You see a positive P in lead 1, this huge PR interval. And then what is this thing right here? And then you see maybe another T wave, or who knows what that is, and P wave, P wave. So we're getting into the blocks realm because you're seeing these lone P waves. So focus with me. Remember, morphology is important. So this is a P wave, this is a P wave, this is a P wave, this is a P wave. So underneath this lead, I'm going to show you the P to P interval is spaced out regularly. And this is actually a regular, there has some components of a regular rhythm because the R to R is also spaced out regularly. Okay, but you see that the R's are doing their own thing, so the QRSs are doing their own thing, and the P waves are doing their own thing. And it's not like the PR is getting longer, 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 and then there's a dropped beat. The QRSs are all regular, so it wouldn't be a second degree block. So this has got to be a third degree AV block. And then again, think about this in the context of a boards question. You see this EKG, what's going to be the treatment for this? It's really important depending on what the question is asking. Like, what's the best initial treatment? You may want to give something to stimulate the heart rate. What's the best definitive treatment? It might be different. Some easy answers, if you see in their home meds that they're on metoprolol, or if they're on diltiazem, digoxin, or amio, it could be that they're overdosed on it. So if they take too much of those medications, you can look like this. And so boards loves to ask questions that provide solutions that are cheap, quick, effective, not million-dollar workup type of answers. So if you see the answer as stop beta blocker and monitor for 24 hours, that might actually be a good answer, a better answer than putting a pacemaker on this patient. If they're not on any of these medications, and this is just happening over time, sometimes we see this in AFib. If you have patients with AFib who have it for prolonged periods of time, maybe they've had RVR multiple times in their life, they can irritate or degenerate the nervous system within the heart. So you can get degradation, and so you can get what's called sick sinus syndrome. So you can get tachycardic moments and then bradycardic moments. And that could be an early sign of what's yet to come, which is like you can get these third-degree AV blocks in these patients. If they're in shock, you want to give them fluids. You can give them atropine. You can do temporary pacing, and then you can give pressors that stimulate beta agonists, so like dobutamine, dopamine, levophed, epinephrine, that sort of thing. Levophed being norepinephrine. All right, so we have the 75-year-old male with a previous MI, so go ahead and review this one. You see that this super narrow, maybe QRS, but there's this abnormal looking QRS here, or whatever this is, maybe ST, T wave. So it doesn't look like a normal, what we're used to seeing. For example, here on the anterior leads, you can see these widened QRSs, which is not normal. You see these T waves that are also kind of abnormal. So what are these lines here? That's not something that we have seen yet so far. These are actually pacer spikes, and if you see a widened QRS and this line right before it, this is probably ventricularly paced, meaning that there's a lead in the interventricular septum stimulating this. But if it's atrially paced, you usually see a narrow complex QRS in these patients. And so this is just a sign of a pacemaker that they have. And so it's hard to tell if the QRS is abnormal, then the T waves will also be abnormal because that's repolarization of the ventricles. So that's called discordance, and that's typical finding. There's nothing like a STEMI that's happening, although there could be. It's hard to tell. It's hard to get a lot of information. It's not that sensitive with patients with these types of pacemakers to come with any findings like STEMI or non-STEMI. It's much harder to figure it out. All right, so we have a 19-year-old male with chest pain, cough, and troponin is elevated. They may even also have a low-grade temp that's forming. So review this one. Go ahead and get back to me. So this patient is tachycardic. We don't have a 10-second strip, but if you follow these, it looks pretty regular. And there is a positive P wave in lead 2. But you do see these ST elevations, it looks like in lead 2, in lead 1. You see some in lead 4, NV5, NV6. You see some STE, looks like depression maybe in V1. But overall, you see like widespread ST elevations, and you don't typically see like reciprocal ST depressions in these patients. So the other thing that I want to show you is the TP segment is always going to be your isoelectric line. So looking at the ST here, it's elevated, and then the PR is actually depressed as well. So it's important to never use these two as your reference point. You should always be looking at TP segment as your reference point. So not only does this patient have pericarditis, they have myocarditis because the troponin is elevated. So it's acute myopericarditis. And so the PR depression, the ST elevation, that's usually from the pericarditis, and the troponin elevations from the myocarditis. And this can be, you always want to keep the differential of MI or cocaine overdose on, especially a young patient like this, on your differential. But that's neither of those. This patient doesn't have MI or cocaine use. So what's the treatment for acute pericarditis or acute myopericarditis? So treatment's going to be NSAIDs, so it could be aspirin, ibuprofen, indomethacin. Those are all fair, initial treatment for these patients, plus colchicine for these patients. And if they can take, NSAIDs maybe because of kidney disease, then steroids is a fair option, like prednisone. And the most common cause for this is going to be Coxsackie-B virus, but a lot of different viruses. I've seen COVID do it. And then pericarditis and pericardial effusions, you start thinking about like, not in a 19-year-old, but other patients you may think of like autoimmune or malignancy, or if they've had radiation to their chest, they can have pericarditis. If they've had an MI and months, like maybe a couple of months ago or 2-3 months ago they had an MI, you can get restrictive pericarditis called Dressler syndrome. And so aspirin would be a good option for those patients. And you should always think about the complications of any of these diseases. So like pericarditis can lead to pericardial effusions and other things as well. You have a 44-year-old female with syncope, she's short of breath, and she's hypotensive. So review this EKG. The main thing that I notice here is that the QRS amplitude is small, then big, then small, then big, then small, then big. So that's the big hallmark finding here. And if this patient had JVD with muffled heart sounds, you should be thinking about tamponade, a large pericardial effusion where the heart is swinging back and forth in the chest, into the pericardial sac. And when the heart is closer to the chest, the amplitudes are bigger, and when they're further away from the chest, they get smaller. And another finding of this will just be like low QRS amplitude, because there's so much fluid and the heart is so far away from the chest that you just don't generate that much of a QRS amplitude that can be picked up. So this is called electrical alternans or isoelectrical alternans. And what is the treatment? So the treatment's going to be, because this is a tamponade, you want to try to get rid of that fluid. So you probably either want to get an echocardiogram, again, depending on what the question is asking. If they're asking, what's the best next test to order, you definitely want to get a stat echocardiogram. But what's the best treatment for this patient? It's going to be a pericardiocentesis. If it keeps happening, then they can do pericardial windows, which is just a surgery that they take a piece of the pericardium to let the pericardial fluid drain. You have a 66-year-old male with history of AFib who presents with nausea, vomiting, and yellow color vision. So vision changes or color vision changes. Go ahead and review this one. So this is on the low end of heart rate being bradycardic. So that's typical finding in this scenario. You also see like the QRSs are not spaced out regularly. So this could be the patient's AFib that's at play. But specifically what I see here is you see these scooped ST depressions. So it's not like a flat ST depression. You see this ST down sloping and then up sloping. And so you see this scooped, we call them scooped ST depressions. And given with his history of AFib, he's probably on digoxin. This is digoxin toxicity, hallmark finding of that. So if they ask you without giving you the medication, what's the best test to order, or what's the best treatment for this patient? Test would be getting a dig level, because the therapeutic window is so narrow. And then giving digifab, like an antibody, to collect that digoxin to decrease the amount of effective digoxin in the system. And this is a finding called mustache sign. So these scooped ST depressions called mustache sign. All right, you have a 25-year-old male with syncope. Review this one. So we have a pretty regular rhythm with P waves that are present, no dropped QRSs. One is positive, AVF is positive, so normal access. But the biggest findings that I see here are almost like these tombstone forming ST elevations in the anterior leads, and you may even see some ST depressions here. But this is the big hallmark finding for this patient, and they're not going to come with chest pain. Although you may be thinking about STEMIing these patients. If they come in with frequent amounts of lightheadedness, dizziness, syncope, maybe they've had a family member who died at a young age, you should be thinking about this disease. So it's called Brugada syndrome. It's genetic. It's a sodium channel defect, and you get these ST segment elevations, especially in V1 through V3. Sometimes you can get T-wave inversions, and the definitive treatment for this is going to be AICD, because these patients are at high risk for ventricular arrhythmias. And so these are like the typical findings. So type 1, you get these ST elevations. You can get them like just a little bit and then scooping downward, kind of like a roller coaster, or some flat ones that we saw in this patient. So there's different varying degrees. But if you see ST elevation in a young patient who's coming with syncope, not chest pain, who's coming with syncope, I already gave you 2 examples of young people who kind of look like ST elevation. One was coarctation. They're not coming in with chest pain with coarctation, but they kind of have these ST elevations. And then this one is another example. Somebody coming with syncope, no chest pain. Somebody died, young in their family, probably have Brugada syndrome. All right, 30-year-old male who came in with for a pre-op visit. Go ahead and review that one. So this hallmark finding, and this is very subtle, and that's why we harp on it so much. We don't see it that often, but you got to capture it when it's there. So we can view on this, especially here, where you see a very shortened PR, where the PR is barely flat for a short period of time, and it's this immediate upslope without a Q wave. So it's just like an early R, and this is called a delta wave. So this patient has WPW. We talked about this earlier. WPW is a form of atrial ventricular reentry tachycardia. That's different than AV nodal reentry tachycardia. And hallmark finding is a delta wave, and these patients are at high risk for SVT or even AFib. And you always want to avoid anything that causes AV nodal blockade. So beta blockers, you don't want to give 9-dihydropyridine, calcium channel blockers, because they're inhibiting the good pathways and allowing the bad pathway, the bundle of Kent, to take over. So then you start getting high risk for ventricular arrhythmias like VTAC, VFib for these patients. You also want to avoid adenosine for these patients. If they come in with tachyarrhythmia, usually like a finding that we would see like with SVT, for example, they might say, like, what's the best initial therapy? And so carotid massage, ice bath, these are going to be your first options before even giving treatments for these patients. But again, this is the one example you want to avoid adenosine and get cardiology involved. But these patients, like, if on boards, they want to ask you what medications to give them. Like, so procainamide is a good first line for these patients for long term. And you can ablate these because you can see where the bundle of Kent is and cauterize it basically. So go ahead and review this one. 86-year-old female who has a history of CHF or is coming in with CHF. So the big hallmark finding here, if you notice, the QRSs are starting to get widened here. If you look at the high lateral leads, one in AVL, there's almost like this RSR prime. So these bunny ears are forming. And another finding is the slurred S. So if you see a slurred S where, especially here, it's like this, it's not clean cut, especially in V6, this could be a sign of a left bundle branch block. And left bundle, we look at high laterals, so one in AVL and V5 and V6. So if you see any bunny ears in any of these, and we didn't see it in V5, V6, but we saw it in one in AVL, then think about a left bundle branch block. If this is a new left bundle branch block, that's concerning. So you may want to do a ischemic evaluation on these patients. If it's an old left bundle, you are not necessarily too worried about it because it could be from old MI, it could be from CHF, it could be from few different things. And one little caveat, one aside, is if somebody comes in with chest pain and you get an EKG like this, you can't do a regular EKG stress test on these patients because they already have an underlying rhythm disturbance that is hard to read if they do have an ischemia. So these patients would benefit from like a nuclear scan or a stress echo, something like that. We mentioned a little bit about R wave progression. You see negative, 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 and you should start seeing positive QRSs in V4, and it's still negative, and it's not even positive yet in V6. So this is called poor R wave progression. So this is what normal R wave progression is supposed to look like, and when you see abnormal, where it's just taking too long to get positive, that can be seen in after an MI especially. So all in all, left bundle branch block and poor R wave progression in this patient. So this one you can already tell that it's irregular. Go ahead and review it though. 59-year-old male who comes in with syncope and lightheadedness. So it's already irregular because the R to R interval is not spaced out regularly. Okay. And the amount of blips on this EKG is 10, so that's on the lower limit, so it's a bradycardia. Again, when you see a bradycardia, think about what's your differential, so you should be thinking about block. So let's prove to see if this is a block or not. So we see a positive P wave in lead 2, that's good. You see the slurred QRS, so there may be prolonged QRS, and there's a P wave, QRS. This kind of looks like the same P wave, so it's hard for me to tell which one's a T wave. If I go vertical, I can see that that's a T wave, so just barely noticeable on the P wave. It doesn't mean that it's not there. So P wave, QRST, P wave, and then no QRS, even though there's like a little blip here. There's no QRS anywhere else vertically. So it's a lone P wave here. P wave, QRS. So if you start seeing a dropped beat, you should be looking for second degree. So it's either second degree type 1, where it's a PR wave, that a PR interval is getting longer, and then it's dropping. But this PR looks pretty normal, then it drops. This PR looks normal, this PR looks normal, then it drops. PR, drops. So this is second degree type 2, or Mobitz type 2. And I can also see morphology in leads 3, and it even looks like in probably AVF. I see these bunny ears again. So if you see it on the inferior wall, which is the right side of the heart, if you see bunny ears, you should be thinking about right bundle branch block. And I also see in the P waves are a little bit peaked here, a little bit bigger, so there may be some right atrial enlargement. If it is, it's borderline. So all in all, this patient has second degree type 2 or Mobitz type 2 with a right bundle and possible right atrial enlargement. We already mentioned about third degree AV block requiring a pacemaker. Second degree type 2 and type 3 are the highest risk for syncope, so usually these patients are good candidates for pacemaker. So as a review, right bundle branch block, if you see it in either V1 or inferior leads, think about right bundle branch block. We already mentioned left bundle branch being like V5, V6, 1 in AVL. So they typically come in with a prolonged QRS and that RSR prime type of form. We have a 70-year-old male with intermittent chest pain for a week, normal blood pressure, and the initial troponin is negative. Go ahead and review this one. This patient has a pretty pronounced bradycardia. There is a positive P wave in lead 2. And we see this bunny ears in lead 1, like a prolonged QRS, and probably ST elevation in AVL, and slight ST elevation in 1, with that same scooped appearance with that ST segment as we saw before. So this patient has a left bundle. And again, if this is a patient coming with chest pain with a new left bundle that's looking like this, and we can even see possibly ST elevations in V2 and V3, I would be thinking about STEMI or non-STEMI in these patients if they don't have a ST elevation, and they should be going to cath lab. So overall, left bundle, ST elevations in 1 AVL, ST depressions is 2-3 AVF, which I forgot to mention, slight here, but a little bit more pronounced here and here. But all in all, you want to take them to cath lab. And what I was just describing with the ST elevations, with the left bundle, the prolonged QRSs, a lot of this information comes through with Scarbosa's criteria. So this is a little bit low yield. I don't think they'll ask you too much about Scarbosa's on boards. It's more like resident level. But if you want to read this, go ahead and you can review that. And if you're interested in cardiology and you talk about Scarbosa's criteria, you look like a rock star on your rotations. And then last but not least, 80-year-old female with a previous MI. I see this EKG a lot, almost all the time in the hospital. I don't think they'll mention this, but it's something to think about, that the different type of bundles that we see. So if you see here, the rate is pretty regular, the rhythm looks to be pretty regular, and sort of see a P wave in leads 2 pretty consistently. So far so good. 1 is positive and AVF is negative, so we have a left axis deviation on this patient. And we're starting to see the QRS widen, so you see this positive R and then this pretty deep S wave. Same thing with lead 3, positive R and a deep S wave and prolonged QRS. You also see V1 is positive. Remember, it's not supposed to be positive or predominantly positive. Same thing with AVR, you see predominantly positive here. You might even see an RSR prime in V2, which could be suggestive of like a right bundle branch block with these findings. And there may even be prolonged PR, so without any drop beats, so first degree AV block, where the QRS is taking more than a big box to generate. So all in all, we have normal sinus, maybe this first degree AV block. We saw this right bundle branch block, and I'll talk about what left anterior fascicular block is. We see this QRS that's prolonged, and we see these small R waves in the inferior lead, or large S waves in the inferior lead. It's almost like they're negative deflecting in the inferior leads. So if you look at this heart diagram with the bundle of His, you have one bundle going to the right, so that's the right bundle branch, and the left bundle is broken into the left anterior fascicle, which goes downward, and the left posterior fascicle, which goes more towards the left. So keep that in mind. Left anterior fascicle goes downward, left posterior fascicle goes to the left. So if one of these is blocked, just like in a bundle branch block, you can get a fascicular block, and the opposite would happen. So you get unopposed if, let's say, the anterior fascicular block is not working, then you just have this unopposed left posterior fascicular block. Not posterior fascicular block, but just posterior fascicle that's unopposed. And the left anterior fascicle and posterior fascicle, these two create this down and towards lead 2 type of direction. So if you have a left anterior fascicular block, then you're going to have negative QRSs in the inferior leads, or a left axis deviation. And if you have a left posterior fascicular block, which is less common, you're going to have the QRS is negative in the lateral leads or a right axis deviation associated with it. And this is just here for you to review. This is probably low yield as well. I left this at the last, just even though we see it so commonly, just something for you to be mindful of. And that's it. This is my EKG lecture. Hope you enjoyed. Let me know what your thoughts were, if you liked it or not. But I hope you enjoyed.